All right, so he graduated from medical school in Athens, Medical School of Athens in Greece. He then worked as a research fellow at Tufts University, and he looked at the role of mast cells in systemic inflammatory diseases. He then completed his internal medicine residency at Albert Einstein and his rheumatology fellowship here at Columbia. And during his time at Columbia, he has been pursuing clinical research on the field of autoimmune-related interstitial lung disease. So he recently joined the faculty here at Columbia in the Department of Medicine, the Division of Rheumatology. And today he's going to present on rheumatoid arthritis, looking beyond the joints. Thank you.
Of RA, so its prevalence is 1%. The peak age of onset is between 35 and 60 years old. Women are more likely to be affected by RA than men, and that's true not only for RA, but also for many systemic autoimmune diseases such as lupus and other organ-specific autoimmune diseases such as multiple sclerosis. Smoking is a very big risk factor to develop RA, and so I just wanted to show here, that's a study from Karolinska, where they looked at the risk to develop RA in patients who have, here the blue columns show patients who never smoked and have 0, 1, or 2 alleles of the major susceptibility genes. So the more genes the patient has, from 0 to 2, there is a dose effect in terms of the risk they have to develop RA. What happens if you combine smoking with the susceptibility genes? So here we have the ever smokers, current or ever smokers, the red columns. So patients who've ever smoked and have no genes, no major susceptibility genes for RA, the risk is slightly increased. If you have 1 allele for the major susceptibility genes and you smoke, you have double the risk to develop RA. But look at that. If you smoke and you have 2 alleles for the major susceptibility genes, you have 20-fold increase of the risk to develop RA. So there is this profound increase in this very strong synergistic interaction between smoking and the genetic background and the major susceptibility genes. So that's another good reason not to smoke, especially if there is somebody in the family with rheumatoid arthritis. So these are the major pathogenetic features of RA. So as I said, patients have the genetic background, the shared epitope, and then there is this influence from some environmental triggers. Smoking has been implicated the most, but also there are some other environmental triggers such as periodontal disease or alterations in the gut microbiome. And that influence from these triggers sets everything in motion. So the genes are not enough. So we need these triggers here. So, and what happens is that there is loss of tolerance to self-proteins, there is production of autoantibodies, and T cells migrate to the joints. But for some period of time, patients have no symptoms in this preclinical phase. They do have the autoantibodies, but have no symptoms whatsoever. Then years later, they develop the clinical symptoms and signs of inflammation. And if we leave inflammation without treatment, it's going to eventually result in joint damage, disability, and some of the patients will require eventually joint surgery. So this slide here shows a healthy joint on the left. And I just wanted to point out at the synovium. The synovium is a very thin structure that lines the inside of the articular capsule. Oops. But also the synovium lines the outer aspect of the articular surface. So the synovium is usually a very thin structure, so usually 2 to 3 cells thick, and its main purpose is to produce fluid that lubricates the joint and also to produce nutrients for the cartilage. Here we have a patient with rheumatoid arthritis. This is a joint of a rheumatoid arthritis patient. So here the synovium becomes very hypertrophic, and actually it becomes invading contiguous structures and destroying everything in its path. So the hypertrophic synovium here, which is called tanus, invades into the bone, causing bone erosions, and secretes cytokines and proteases that degrade the cartilage here. And the presence of those erosions and the cartilage thinning are the main factors that cause disability and impairments in the disease. So this is a histopathologic image of the panus, this very hyperplastic and hypertrophic synovium, and you can see how it invades into the bone and into the cartilage, causing this significant destruction here. This is an arthroscopic image of a knee that has early RA. So here the patient has prominent angiogenesis, these prominent vessels, and maybe some slight hypertrophy here. But if we leave this knee untreated for years, eventually we see this tumor-like appearance of the synovium, which is very hypertrophic and inflamed, and gets this like tumor-like appearance. So what are the main features of RA when we see patients in the clinic? So RA presents with the cardinal signs of inflammation, that is pain, swelling, tenderness, warmth, but not much redness. As a matter of fact, if we see a lot of redness, we actually think of alternative diagnosis such as infection, septic arthritis, or crystal-induced arthropathy such as gout or pseudogout. So, and here in this picture, we see the left hand of a patient that has swelling in the second and the third proximal interphalangeal joints. So the proximal interphalangeal joints and the metacarpophalangeal joints are very commonly involved in RA. For some reason, the distal interphalangeal joints are almost always spared. And we don't know why this is happening, but we almost never see involvement of the DIP joints in RA. It's the PAPs and the MCPs which are involved, and the wrists, of course. So in early RA, we usually have involvement of the metacarpophalangeal joints and the proximal interphalangeal joints, and the wrists. It can affect any other joint in the body, the exception being the thoracic and lumbar spine, and as I said, the distal interphalangeal joints. So many times patients come to the clinic and say, I have back pain, do I have RA? So RA almost never affects the back. So except for the thoracic and the lumbar spine and the distal interphalangeal joints, RA can affect pretty much any other joint. So here we see the progression of RA from early disease to more advanced stages. So in the picture here, we see the early manifestations of RA. So there is some subtle swelling. It's not very prominent, but there is some swelling here of the third proximal interphalangeal joint of this patient. If we leave the disease untreated, it's going to progress to more severe and visible deformities. So here the patient has swelling of all the MCPs, but not only swelling, there is subluxation, which is this downward dislocation of the toes, of the fingers relative to the metacarpal bones. And this is due to laxity of the tendons and sometimes rupture of the tendons of the hands. Also, this patient here has what we call swan neck deformities, which is hyperextension of the proximal interphalangeal joint here and flexion of the distal interphalangeal joint here. And later on, years later, if the disease is left without treatment, we see this significant ulnar deviation of the fingers relative to the metacarpal bones. We see this profound interosseous muscle atrophy here in the dorsal aspect of the hand. They develop this Z-shaped deformity of the thumb here. And the patient also here has rheumatoid nodules in the PAP joints. So it's a really destructive process if we leave it